Hello, everybody. Greetings from Heart Care Foundation of India. I am Dr. K. Agarwal, President, Heart Care Foundation of India. Basic aim to talk about the facts, evidences as far as COVID-19 is concerned. Let's have the headlines of the day. Monoclonal antibodies that stop the coronavirus from spreading in the body are among promising strategies for averting severe illness from COVID-19 before the vaccine arrives. ICMR's second Sero survey shows Indians far from achieving herd immunity, though some states may have been towards reaching a herd immunity, but not India as a whole. The CSIR Center for Cellular and Molecular Biology has launched a study in the hospital environment to assess how long and far the coronavirus can stay in the air. Let's wait for the study results. Beijing asked frozen food importers to shun countries with severe coronavirus. This is after they found some of them were infected with the virus. Important thing, everybody should know this particular aspect. The Supreme Court of India allows COVID-19 positive aspirant to take common law admission test 2020 examination in isolation today. That means nobody's career should be lost. Therefore, Supreme Court allowed a COVID-19 patient to give his exam in isolation conditions. The topic is single platelet or a dual platelet inhibitors. That means we are talking about SAT or DPAT, how we can call them as. Normally, we give antiplatelet drugs for prevention of first or second heart attack. Sometimes we give one, sometimes we give two. Because this program is also live on Facebook, they should understand that there are two types of blood clots. We say white blood clot and the red blood clot. White one are platelet clot and the red one is a non-platelet clot. It's a RBC clot. Today we are talking about the white blood thinners, single dose or in dual combination. Let me introduce my faculty. I have with me Dr. Jamshed Dalal, 40 years of experience in the field of interventional cardiologist, was associated with National Heart Hospital London. He was associated with University of Wales, UK, Queen's University in Canada, and many others. He has helped to establish the cardiology departments in Mumbai, including Hinduja Hospital, Leelavati Hospital, and presently he's the Director of Cardiac Sciences at Dhirubhai Ambani Hospital, Kokela Bean Hospital in Mumbai. Thank you and welcome to our show.
Thank you.
Our second guest is Dr. Prakash Kumar Hazra. With over 27 years of experience, he has a vast teaching and training experience on several national and international platforms, has delivered and participated in hundreds of lectures and symposiums. His interest is on SGLT2 inhibition, more than 30 lectures on GLP-1 receptor antagonist, over 50 lectures on ARNI and heart failure, and he was the first to perform prostate artery embolization in Eastern India, and many more things with us. Welcome to our show, Dr. Hazra. I'll start with Dr. Hazra. I will start with Dr. Hazra because the subject will be discussed in such a way. I will ask Dr. Hazra to give a small presentation with slides, followed by Dr. Dalal, and then we will start our discussion. And later in the last 5 or 10 minutes, we'll invite people who are participating. They can come and ask live questions with that. Those who are watching this program, kindly circulate and forward the link and share the link with others. Remember, Dussehra and Diwali are on the way. You are not going to receive mithai from anybody, because if you receive any sweet from anybody, the first thing will come in your mind is, I hope is it not carrying corona. And the time you have that feeling it is not carrying that corona, the purpose of gift is over. So the best gift today in today's era is to forward a link of an interesting lecture. So therefore share this link as a gift to your colleague so that they can join right away. Dr. Hazra.
Yeah, thank you, guests and my senior teachers, attendees. So today's talk will be on SAPT or DAPT. And I'm an interventional cardiologist, and I do treat COVID patients. So there are two group of people. One is COVID positive ACS and COVID negative ACS. As Professor Agarwal was mentioning, the life is very difficult to treat these COVID positive ACS patients. Before COVID, we had two agents, aspirin and ticagrelor. That was my favorite DAPT. But after this TREAT trial or Tycho trial, which originated from South Korea, and Twilight ACS trial, we can stop aspirin after 3 months. And after 3 months, you can continue either prasugrel or ticagrelor as long as you want if there is no high bleeding risk. Now, some of these patients, they do have comorbidities and high risk factor, multiple risk factors. So these are the people who develop COVID positivity. They need a third agent, which can, in one hand, increase bleeding risk, but on the other hand, can stop or prevent a devastating complications like stent thrombosis, pulmonary embolism, venous thrombosis, or any device-related thrombosis, whether it is dialysis line, you have a pacemaker recently put in the subclavian, your subclavian vein can get thrombosed, you can get a stroke, you can get mesenteric ischemia, anywhere, everywhere. If you have a device, especially these people are very vulnerable to thrombosis. Now, it's very difficult to put them on continuous heparin or low molecular heparin once they leave hospital. And we usually put them on preferable double antiplatelet, especially in low bleeding risk people with a new modality called NOACs. And there are some NOACs like you have in the market 3 NOACs, dabigatran or apixaban. You can choose either of them. You have to look into their creatinine level. So life has become easier before COVID, but much more complicated because if you combine 3 agents, there is a high chance of bleeding. So these new trials, and you have ISA React 5 from ESC, and it is originating from Germany, German Heart Center, and a lot of centers in Germany, they prefer only prasugrel. Now, prasugrel is 3 conditions you should remember, like age, weight, and it should be applied only on the table. So in 2020, prasugrel, there is a resurgence of prasugrel, 10 milligram, and ticagrelor was old, very good drug. You can continue clopidogrel if there is an economic reason, but clopidogrel resistance is also important. APCI, again, single antiplatelet plus NOAC. So to summarize then, it's better to drop aspirin if you're using very strong antiplatelet, and we have to wait for the trial for the very first day of dropping aspirin like APCI, even in ACS. If you're treating without stent, perhaps double antiplatelet can be continued. If there is aspirin allergy or has history of bleed in the past, you can continue with single antiplatelet like ticagrelor or prasugrel. With that note, I'd like to thank. If you have any further question, I'll be glad to answer that. But I'm waiting for Professor Dalal to continue and have conversation after he finishes. Thank you, sir.
Dr. Dalal.
Rito's got my slides. She's going to show them. I think what we should remember is that when we talk of antiplatelet agents, the most commonly used antiplatelet agent is aspirin. We use it as a preventive medicine, and there's a lot of debate about the use of aspirin for prevention of coronary artery disease. But once you develop coronary artery disease, what we call as a secondary treatment for coronary artery disease, aspirin has become almost synonymous for lifetime use. The question is of two folds when you talk of antiplatelet agents, especially dual antiplatelet agents. First is patients with coronary artery disease who have not undergone PCI, and the second is patients with coronary artery disease who have undergone PCI. Those who have undergone PCI, this is the main group where dual antiplatelet therapy is important. And people either use aspirin along with clopidogrel, prasugrel, or ticagrelor, and there are various pros and cons for each of the use of these three. The recent data, there are a number of recent trials, but I'm going to put up the most recent trial, which is the Twilight Trial, which was very recently presented at the ACC. In the Twilight Trial, they did patients with high risk PCI, so they were high risk patients. All of them had undergone a PCI. After the PCI, for the first 3 months, they were kept on both aspirin and ticagrelor. And at the end of the 3 months, aspirin was stopped and only ticagrelor was continued till the end of 1 year or 15 months. The aim of the study was that when you combine aspirin and ticagrelor both, then of course the chances of bleeding increase. So they wanted to see whether stopping the aspirin and continuing only ticagrelor, which is a much more potent and effective antiplatelet agent, we would be able to get lesser bleeding but still have the safety. Next slide, please. So in Twilight Trial, the main thing was to see whether bleeding was less by stopping aspirin. And clearly, as you can see, the upper is the aspirin plus ticagrelor, the red one, and the lower blue one is the only ticagrelor. And clearly, by stopping the aspirin at the end of 3 months, you reduce the bleeding chances. Now, bleeding is a big problem in patients who are on antiplatelets, and therefore, anything which reduces bleeding is of great benefit. The question is, will that produce more ischemic events by stopping aspirin? Next slide, please. And clearly, you see that there is not much difference in terms of the primary endpoint of death, MI, or stroke. That means Twilight study, like some of its earlier studies, has shown that after 3 months, if you stop aspirin and continue only ticagrelor, it is pretty safe and it reduces bleeding events. So that's a great advance, and most doctors will now shift to using only a single antiplatelet after 3 months. Now, there is no data of using only single antiplatelet, only clopidogrel or only prasugrel. So this study was done with ticagrelor. We would need studies with only clopidogrel or only prasugrel. There is concern with clopidogrel because about 20% of patients have resistance to clopidogrel, and therefore it may not be the best option. So this is the way to continue dual antiplatelet therapy in a safe way for up to 1 year to 1.5 years. Now the question is, what do you do in patients who are got no PCI or those who want to have only coronary artery disease? Next slide, please. So the conclusion, as I mentioned for this trial, was that you could use ticagrelor alone without using aspirin in patients with diabetes who had undergone high-risk PCI. Next slide, please. The next trial was called the Themis Trial. This was done in two groups of patients. One is Themis Trial for stable coronary artery disease patients, and a Themis PCI group where patients had undergone PCI. In the Themis group, what they found was in patients with stable coronary artery disease, continuing due antiplatelet drugs for a long time produced a lot of bleeding. In the Themis PCI trial, they showed that if you had undergone PCI, continuing two drugs for a longer period of trial was beneficial. Can I have the next slide, please? So if you look at the division into two, the left-hand side is those with a history of PCI, the right-hand side is those without a history of PCI. And then you look at the ischemic events, which is light blue, the bleeding events, and what they now call as the net clinical benefit. Especially when you're talking of antiplatelet agents, you have to talk of net clinical benefit. That means bleeding versus ischemia. And if the net clinical benefit is in favor of one, then that is a better form of treatment. So if you see patients on the left-hand side with a history of PCI, you can see that the ischemic events are significantly reduced. And this trial was carried on up to a period of 3 years. So it was a long-term trial, not just a 6-month or a 1-year trial. And the bleeding events were not too many. And the net clinical benefit was in favor of using two antiplatelet drugs. But if you look at the right-hand side, those patients who had chronic coronary syndrome, stable angina is now designated as chronic coronary syndrome. In that group of patients, you see that there is not much change in ischemia, but there is an increase of bleeding, and the net clinical benefit is against the use of dual antiplatelet agents. So clearly, the data shows, after putting everything together, I would suggest the data shows two things. One, in those patients with coronary artery disease who've undergone angioplasty, you should continue aspirin and ticagrelor for 3 months. After that, you should stop the aspirin and only continue ticagrelor. Now, how long you should continue ticagrelor or how long you should continue dual antiplatelets, I think at the end of 1 year, you have to individualize. If the patient has got a high ischemic risk and has had a previous PCI, it is better to continue two antiplatelet drugs. If, on the other hand, the patient has not had a history of PCI, or the patient has got low ischemic risk, or the patient has got a high bleeding risk, then it's better to stop the dual antiplatelet therapy after 1 year. So this is what the present situation is. Of course, there's a lot of debate about this. Next slide, please. There's a lot of debate about this. So this was the conclusion of the Themis trial. So these are the two latest trials which have brought on some more clarification. But I think people still debate about it. People still haven't changed their guidelines. But the present concept is that in patients, you can stop one antiplatelet. It's also important that most of the studies are now stopping aspirin rather than stopping the clopidogrel or ticagrelor. In the past, what we used to do is to stop the clopidogrel and continue aspirin for a long period of time. But it's clearly been shown now that aspirin itself can be quite a bleeding hazard, especially gastrointestinal bleeding and cerebral hemorrhage. So, therefore, the general feeling is that if you're going to use a single antiplatelet, it's better to use either clopidogrel, more preferably ticagrelor, especially if PCI has been done, and stop the aspirin. So, thank you. We can take the questions after this. Thank you very much.
So thank you, Dr. Dalal, for a wonderful presentation. Let me come back to a couple of situations, and maybe after 10 minutes, we'll invite the public to join in. My first thing is very clearly that is, yes. My first thing is when we said that 1.5 year, if the person, let's take a situation, a patient has undergone surgery, stenting, or any intervention where antiplatelets are a must. In such a situation, if we say that stop aspirin and continue, say, ticagrelor for 1.5 years, what about after 1.5 years? Because we are supposed to give them one antiplatelet lifelong. Initially, it was lifelong. Now, if we take aspirin out, can we continue one of the other antiplatelet lifelong?
What I feel is that the present concept is that at the end of 1 year or 15 months, you should individualize the particular patient in terms of whether you should continue both the antiplatelets or a single antiplatelet. If the patient has got high ischemic risk, for example, he's had multiple interventions, he's had a bypass followed by PCI or 2, 3 PCIs, or he's had a complex PCI where he's got a stent and bifurcating left main stent and multiple stents, then it is better to continue for a longer period of time, maybe even lifetime, in which case you may continue either aspirin or aspirin plus clopidogrel both. There is no real data continuing only one drug for an indefinite period of time like there has been for aspirin. We all have been using aspirin indefinitely for years and decades now, but that data is not available for ticagrelor. There is no data looking at 10 years use of ticagrelor because it's not been available for so long. So that point remains debatable. If on the other hand, patient is a very simple patient, single payer stent, no diabetes, no other risk factors, then certainly you could stop the second antiplatelet and just continue one drug. Now, that also there is a debate whether you should continue aspirin indefinitely or whether you should continue ticagrelor. You must remember that ticagrelor is more expensive. It definitely has more bleeding problems compared to aspirin. It also, in about 10 or 12% of people, produces breathlessness for which it may be stopped. So I think individualization for long-term management is what we usually suggest is the best option.
The second thing is no PCI, simple stable coronary artery disease. That means I'm talking about diabetics. I'm talking about high LDL or a plate. If you have intima media thickness, which is thick, or a patient has coronary artery disease on medical treatment, there also we normally say lifelong antiplatelet. Now here, what will be the situation now?
Dr. Hajra, would you like to answer? Yeah.
Yeah, if you're talking about primary preventions, that he's got only carotid intimal thickness, or he's got atherosclerotic cardiovascular disease, which has not manifested in the form of any stroke, MI, ACS, or peripheral vascular disease. So unmanifested atherosclerotic cardiovascular disease, above 50 years diabetics, there was consensus that aspirin should be given. There is no role for primary preventions of disease by ticagrelor or prasugrel. Prasugrel is purely for PCS. And as you were asking, sir, Professor Agarwal, The medically treated patient, primary prevention, if you have a calcification now on CT angio, so these are the group of people. There's a MESA study published this year only, and last year also some data available. The multi-ethnicity study in US, they said if your calcium score is more than 99, you can put them on aspirin, especially diabetics who are high-risk people. Now, if you have a manifested atherosclerotic cardiovascular disease like MI, but has not undergone a PCI or CABG, there are two types of life today. One is to remain on Themis like, because Themis says if there is no MI or past MI, if there is a no MI, no myocardial infarction in the past, so Themis style says you can stay on aspirin plus ticagrelor, no prasugrel. If you have MI or polyvascular disease, the life can be aspirin plus rivaroxaban, as you were saying, newer oral anticoagulant, that too small dose, 2.5 milligram twice in a day, because there is less bleeding than ticagrelor aspirin, mortality benefits, cardiovascular death benefit, prevents stroke by 70%, prevents amputation by 70%. So that is called DPI, sir.
So if
So
I may,
I want to come back to now main issue of today's discussion, and that's a hypercoagulable state produced by COVID-19. We know COVID-19 produces hypercoagulable state in everybody. We know that normally when COVID-19 virus enters our body, it is supposed to produce interferon 1, that is supposed to produce gamma interferon, and that is supposed to take care of the virus. But somehow the nuclear capsid of the virus causes interferon resistance. So interferon pathway does not take place. There is a thymus TH1, that is thymus helper 1 cell stimulation, which produces interleukin 6, which goes to the liver and produces CRP, which also increases fibrinogen. This fibrinogen increases the clot formation and resultant high D dimer. That means this is the only condition where you have both fibrinogen high and D dimer high. Normally, when D dimer is high, fibrinogen is consumed, and in that situation, fibrinogen should become low. Therefore, this virus causes very strong uh, hypercoagulable state, which can cause thrombosis of the grafts, stents, of heart attack, paralysis, anywhere, retinal artery occlusion, cerebral vein, cavernous sinus thrombosis, and whatnot. So this is one of the strongest hypercoagulable state. In such a situation, Dr. Dalal, I need to start a prophylactic anticoagulation, say dabigatran. I'll give you only one example. It can be rivaroxaban or apixaban. Let's take the example of dabigatran as an example. If I want to give it, in that particular situation, I need to discontinue the platelet agent or I continue. If I continue, if it is a single antiplatelet, it's okay. But if the person is on dual antiplatelet, do I need to omit one? And if yes, which one?
one thing is certain that if you combine novel anticoagulants and antiplatelets, you're going to get increased bleeding. So there is no question about that. Whenever you give a combination of these, you're going to have increased bleeding, and the bleeding could be intracerebral bleeding and catastrophic effects. So therefore, we do not recommend combination of the two unless there are exceptional circumstances. So if, for example, a patient has got COVID and he's on, say, dual antiplatelet therapy, and we have to start a NOAC, I would certainly stop the two. Out of the two, I would certainly stop one of the antiplatelets. I think giving two antiplatelets and NOAC is very dangerous. Out of the two, which one would you stop? The general concept today is that we should stop the aspirin and continue clopidogrel with NOACs. But a number of studies have shown that uh, clopidogrel plus NOAC is a safer combination than aspirin plus NOACs. We do not recommend ticagrelor or prasugrel with a NOAC because the bleeding chances are very high. Now, again, whether you should continue even a single antiplatelet or not depends on the patient's cardiac condition. If the patient is taking, say, aspirin or clopidogrel for a stable angina, I think you should stop the antiplatelet and only give a NOAC. In fact, even after PCI, if the patient has got, say, atrial fibrillation and he's on a NOAC, the suggestion today or the recommendation is stop both antiplatelet agents after 1 year and only continue NOAC. Now, if a patient has had a recent stent, so unfortunately, if a patient's had a recent COVID, and as you know, some of them get an infarct and he's got a stent and now he's on dual antiplatelets, then of course I would be a little bit worried about stopping both the antiplatelets in such a situation. In such a situation, I would give Novax plus clopidogrel and stop the aspirin. So clearly, the answer is if you can avoid both antiplatelets, avoid so. If you cannot avoid and you have to give both, then give only clopidogrel. Unless you just put a stent, like just say 24 hours ago, then maybe you could give it for 1 week, a combination of two antiplatelets and NOAC, but certainly not longer than that, because I
So
think bleeding is a big issue.
जो लोग इस प्रोग्राम को देख रहे हैं और सोशल मीडिया में देख रहे हैं, थोड़ा सा हिंदी में समझा दूं, क्योंकि कई सारे लोग ऐसे भी होंगे जो मेडिकल नहीं होंगे। जिस प्लेटफॉर्म में हम अभी तक थे वो डॉक्टरों का प्लेटफॉर्म था, पर पब्लिक के लिए एक चीज़ समझ लीजिए, क्योंकि घर घर में डायबिटिक्स हैं, घर घर में हार्ट के पेशेंट्स हैं, घर घर में एंजियोप्लास्टी हो चुकी है, घर घर में बाईपास हो चुका है। वो सारे लोग जिनको बोला गया है घर में बैठो, कोमॉर्बिड हो, इंस्टीट्यूशनलाइज ट्रीटमेंट होना पड़ेगा, हालांकि अब होम क्वारंटाइन अलाउ कर दिया गया है। In such cases, they may be put on prophylactic newer oral anticoagulant drug, dabigatran, rivaroxaban, or apixaban. If you are put by your doctor on an oral anticoagulant drug, make sure that your father, grandfather may also be on a white blood clot thinner. Remember, aspirin, clopidogrel are white blood thinners, and dabigatran is a red clot thinner. And if your doctor is putting you on a red, remind him that my father is already on a white clot thinner, what to do. In that situation, if he is on a two white clot drugs, one may be reduced, one may be omitted, and that has to be decided by the treating doctor, the treating cardiologist. Cardiologists may have their own preference, but Dr. Dalal has clearly said that if you want to give one, that has to be clopidogrel. The reason being, other two may cause more bleeding. So ask your doctor, and if your doctor say continue aspirin, debate with him, discuss with him. That in one of the program where talks with Dr. K.K. Agarwal, Dr. Dalal had suggested that it should be clopidogrel which should be introduced. In such a cases, if you discuss with your doctor, you are not contradicting your doctor, you are doing a shared decision. Shared decisions today are welcome. No doctor will say that I know better than anybody. So therefore, you can debate with your doctor and say, hey doc, I have got COVID-19. My doctor of COVID doctor has told me that I will be on a newer anticoagulation for at least 28 days. After 28 days, the drugs may stop. During these 28 days, can you stop one of my antiplatelet or substitute? I'm only on aspirin, substitute with another safer medicine which will not react with dabigatran. That's your duty, and that's what we expect, because this COVID has taught us so much about COVID. Now a person wants to discuss with his doctor every decision, and that's the reason of this show. This show basically empowers you to discuss and debate with your doctor, but not contradict them. Don't fight with them, but you can politely discuss with your doctors that I want that no risk of bleeding with that. Am I correct, Dr. Jamshed?
Yes, absolutely. But we must always keep the risk of bleeding in mind. In fact, as Dr. Hazra has mentioned, that nowadays, even for primary prevention, which we used to use rampantly, we used to tell everybody take aspirin for preventing heart attacks. Number of recent trials have shown that yes, aspirin does prevent a heart attack, but aspirin also produces bleeding. So please make sure that you are not a high bleeding risk patient. Suppose a patient had black duodenal ulcer and has bled, very dangerous for that patient to take just prophylactic aspirin generally. So before you take any blood thinners, including aspirin, please be very mindful that you may get bleeding and discuss in detail about the benefits of the taking the medicine versus the risk of bleeding. So that's very important these days.
So why Dr. Dalal has told about this is because this virus also causes COVID gastritis. It also causes COVID gastroenteritis. It also causes inflammation of the small intestine. It can cause cholecystitis and appendicitis like picture. and it does reduce hemoglobin by 1 to 2 gram. There may be a micro level of bleeding in the small intestine, we don't know. So therefore, and it also causes low platelets in some cases. Therefore, it has to be a shared decision, and it has to be a decision on a case-to-case basis, and with monitoring of parameters. So you're watching Med Talks with Dr. K.K. Agarwal. This is 70th episode, and I have with me Professor Dr. Jamshed Dalal and Dr. P.K. Hazra. I will invite some of the people if they want to come and ask their questions, but I'll ask them, invite couple of people जिनको एस्पिरिन पे हैं या हार्ट पेशेंट्स हैं या डायबिटिक पेशेंट्स हैं. So I'll take one example. This is Geeta Khilani. Geeta ji, can you come here to discuss personally? I can ask you with that. She says, my mom is 75 years, a non-COVID yet. She has angina, hypertension, and diabetes. She takes atorvastatin 10 milligrams, Stanlip 145, aspirin 75, and metformin 5, amlodipine 5, atenolol 5. And if she gets COVID on day one, what should she do? If she gets COVID, because she is a high risk, and we normally recommend in such cases a blood thinner on day one. That means if she has to be put on ephogratran on day one, what should we do? Dr. Hazra.
Yeah,
Should
that's
we
it.
continue?
Perfect. It's a perfect patient, high risk patient, 75 years by age, and lady, diabetic, hypertensive, on multiple medications. I'm not arguing the doses and the combinations of medications here. So if I want to put my thoughts here, if she wants to have anything, any new drug, as we are discussing, on top of one drug, if you add another drug, which is a blood thinner like, you have propensity for bleeding. So if your mom has any history of bleeding in the past, whether it is GI bleeding or intracranial bleeding, she is not the right candidate for, or it has to be used very cautiously with another second agent. And we have now newer agents which are called red thrombi breaking or preventing agents. These are called oral anticoagulant. Previously, it was rat poison. Because of high incidence of bleeding of these rat poisons, we have twice in a day some newer anticoagulants. But before that, you must consult your doctor. You have to tell me that whether she has bled in the past. But if you have this kind of patient who did not bleed, high bleeding risk is not there, you can take help of local doctor. If he prescribes some newer oral anticoagulant, it has to be shared decision making between you and your treating physician. And if he wants to give, he will explain you that you may need this kind of new agents. These are available, attractive, affordable, and very easy solution for your DVTs or any thrombosis, which can give rise to many deaths in COVID situation. I hope she doesn't get it.
ओके लेकिन फिर भी अगर हो जाता है डॉक्टर दलाल जैसा आपने कहा तो आई विल से दैट शी कैन स्टॉप एस्पिरिन बिकॉज शी इज नॉन पीसीआई and continue dabigatran for 10 days or 28 days as the case may be, and then shift back to aspirin.
That sounds safe to me because she doesn't have any acute coronary syndrome. She doesn't have an angioplasty bypass surgery done. So stopping aspirin for a couple of weeks would be relatively safe for her, because especially because you're putting her on a dabigatran or a Novax, so that would cover some part of her problem. I think at her age, with the multiple problems including hypertension, giving aspirin plus dabigatran would definitely carry an increased bleeding risk. So I would be quite happy to stop her aspirin, give only Novax. Once the Novax are over, then she can go back to her aspirin.
जी गुप्ता जी पूछ रहे हैं डॉक्टर आर यू सेइंग वी कैन गिव क्लोपिडोग्रिल इंस्टेड ऑफ एस्पिरिन अलोंग विद dabigatran? Yes, Mr. Gupta, you have heard this correctly, and this is absolutely what we meant in this subject. क्लोपिडोग्रिल स्टार्ट करने के 5 महीने बाद मुझे नाक से ब्लीडिंग हुई, डॉक्टर ने क्लोपिडोग्रिल बंद कर दी. अगर कोविड हुआ तो मैं क्या करूंगा? इन्होंने एज अपनी नहीं लिखी है. डॉक्टर दलाल.
Yeah, but the COVID has got nothing to do with clopidogrel. Anyway, you said you have stopped clopidogrel. If you get COVID, you contact a doctor and get COVID treatment accordingly. As Dr. Agarwal said, you might be put on a novel oral anticoagulating agent. Since you're not on clopidogrel, there is no problem in terms of bleeding. So because you had, I do not know why you were started on clopidogrel, but that's something which you'll have to discuss with your doctor.
ये लास्ट दो सवाल हैं, एक डॉक्टर हाजरा के लिए और एक डॉक्टर दलाल के लिए। पहला सवाल डॉक्टर हाजरा के लिए सुनील मेहवरारा जी सवाल कर रहे हैं, हाउ फ्रीक्वेंसी PTINR टू बी डन इन CAD पेशेंट्स ऑन एस्पिरिन टू evaluate bleeding risk? डॉक्टर हाजरा।
Yeah, if you are on antiplatelet, there is no need for PT INR. Only with your rat poison, you need to check your INR. And second reason is before initiating any second therapy, whether it's warfarin or heparin, and if you're elderly, it's better the doctor should advise to check INR on top of aspirin. If you have a chronic liver disease, special situation or something in the past, these are the people you have to have INR. Otherwise, there is no need for to spend money with newer oral anticoagulant checking INR, because the INR will never be reflected whether you are taking good dose, bad dose, or not taking anything. So INR is not required on aspirin.
मेरा सिर्फ एक लास्ट सवाल है जो एक लेडी ने पूछा है कि मेरे को कोविड है, मेरी उम्र 45 to 50 के बीच में है और मेरे को ओरल एंटीकोagulation डेबिगेट्रॉन पे डाला गया है बिकॉज ऑफ माय हार्ट हिस्ट्री इन द पास्ट। आई एम ए मेंस्ट्रुएटिंग वुमेन, तो मेंस्ट्रुएशन के टाइम पे क्या डेबिगेट्रॉन से मेंस्ट्रुएशन की ब्लीडिंग बढ़ जाएगी या नहीं बढ़ेगी? डॉक्टर दलाल।
It is possible. If you have any bleeding, you will increase the chance of bleeding because that's what the blood thinners do. And yes, you will have increased menstrual bleeding as well. But I think in this situation, you have to see the, again, in every situation, you have to see the risk and the benefit. Now, if you got COVID and you're going to have serious thrombotic problems, including heart attack or pulmonary embolism because of COVID, then the blood thinning is very important for you. The side effect in this case would be increased menstruation, which is not going to be fatal for you and which can be taken care of by giving iron supplementation or even if required blood transfusion. So I think in this particular situation, if you're ill with COVID, it is better to take the oral anticoagulation because the benefits of that will be more than the increased menstrual problems that you will have.
I think this seminar should be able to answer many of the queries of our doctor colleagues, MBBS doctors, even specialists. For a specialist, they would know from this how to answer queries of the patients who are watching, healthcare workers who are watching. And this, if you feel that this discussion was useful, even if one life is saved and one treatment is corrected, we will be happy to conduct such seminars in future. That's all for today. Let me thank both Dr. Jamshed Dalal and Dr. P. Hazra to be here with us.
Thank you very
And
much.
all my viewers, kindly do circulate the link as a gift to your colleagues. We'll be back tomorrow 7 p.m. with another show. Tomorrow, remember, what a hard day. Call your cardiologist and wish him a good what a hard day. We, on behalf of Dr. Jamshed Dalal and PK Hazra, we wish a good corona-free, and even if you get a corona mortality-free heart life to everybody who is a heart patient. Thank you very much. We'll be back tomorrow, 7 p.m. with another